Welcome everyone, and welcome to the webinar AI for European Healthcare, Enhancing Patient Care, Privacy and Collaboration. We are bringing together three leading European AI in healthcare projects, Artemis, Genial and Thrive, to explore how artificial intelligence is transforming diagnostics, ethics and personalized medicine. Let me introduce our speakers today. First, Dr. Georg Lang, part of the Artemis project, a Horizon Europe initiative focused on AI-driven precision diagnostics in radiology and pathology. Dr. Langs is associate professor at the Medical University of Vienna and leads the computational imaging group. His work bridges machine learning and clinical decision making, particularly in cancer diagnostics. Dr. Langs, welcome. Happy to have you with us. Our next speaker is Dr. Jakob Kather, involved in the Genial project, dedicated to AI-powered liver cancer diagnostics and treatment personalization across Europe. Dr. Kather is physician scientist and professor at Technische Universität Dresden, with expertise in deep learning for digital pathology and radiomics. Welcome. And our last speaker, Dr. Manfred Claassen, from Thrive Project, aiming to revolutionize liver cancer care through AI-guided clinical pathways and decision support. Dr. Claassen is a professor of computational medicine at the University of Tübingen and a pioneer in integrated AI into real-world oncology workflows. So, gentlemen, thank you very much for joining us today, and let's start the discussion. So, our first topic will be focused on AI integration in healthcare. So, my first question is to Dr. Langs. What role does AI play in enhancing the precision and efficiency of diagnostics in your project Artemis?
Thanks, Veronica, and thanks for having me. So I'll talk a bit about what we are doing in the Artemis project, and there we are focusing on liver disease, but also on the link between liver disease and cardiovascular disease. And we have chosen a couple of use cases to see what we can do in order to be better at predicting what happens to patients, but also be better at predicting what happens with once we are applying a certain treatment. And just to give you a couple of examples, so we're looking at fibrosis progression in diffuse liver diseases. We're looking at the link between the fibrosis in the liver and heart failure. We're looking at cardiovascular complications and specific treatments for these liver patients. And the two questions that we are trying to tackle is, one is, can we early on predict when we are using the imaging data, so we, for example, magnetic resonance imaging data together with the laboratory values and other characteristics of these patients, can we predict risk, but can we also predict the response to specific treatment? And I think the special point about the project is, on the one hand side, that we are not only focusing on the liver, but we are realizing that we are starting to be more successful if you're looking at the entire system and also consider these links between different organs, between different systems in the human body, like, for example, the cardiovascular system and the liver system, and how they interact during the disease, but also during the treatment. And the second thing that I'm very, very curious about, because my background is more coming from the machine learning, from the method side, is that in this project, we are bringing the community around machine learning, which is right now pretty focused on prediction models, together with the community of simulations experts. So experts who are really studying mechanisms, mechanistic relationships, and try to kind of recreate them to understand what is happening in a disease and to understand what is happening during the treatment of a disease. And so I think this link is one of the focus points in Artemis, to see, can we use machine learning to extract features from patient data that can be the basis for new simulation methods, or the other way around, can we use simulation methods in order to kind of combine that with machine learning algorithms or models to create new explanations of the mechanisms that are ongoing during this disease and treatment. So predict for the individual patient in order to support treatment decisions. I think that's maybe the immediate relevance for the clinical world, but I think more long-term it's important also to develop new methods that not only predict but also start to explain a bit what is happening under the surface in these treatments and in these diseases.
Thank you, Dr. Langs. Artemis is definitely one of the innovative project ELPA is part of, and we really like how the whole consortium is fighting for all of this better understanding also for us patients, and also connection between heart and liver as an organ. It's very interesting, innovative for us. But I am continuing with my question to Dr. Claassen. So how does AI support the decision-making process for clinicians within the context of liver cancer management? You are part of Project Thrive.
Yes, thanks a lot for the question. So maybe to give also a brief context on what we are doing in the Thrive project. The Thrive project aims to better understand liver cancer. On the one hand, how liver cancer develops, as well as how liver cancer can be treated using immunotherapies. And in order to understand these processes better, one big part of the activity in the Thrive project is to acquire highly informative molecular data of liver tissue for different types of molecular entities, proteins, mRNA expression levels. But another type of data that is right now very exciting and being associated with liver cancer, not only with liver cancer, but also with other cancer entities, is the effect of microbiota that are present in the gut as well as in the liver. And for this, a lot of molecular data is acquired in the Thrive project. We are using AI and machine learning in order to integrate this type of data to understand the mechanisms of development of disease as well as the response to immunotherapy. To this end, we are using AI methods in order to use immunohistopathology images and associate this with patient characteristics like therapy outcome, inflammation, and similar phenotypes, as well as using AI methods in order to use the molecular data, for instance, the spatial biology data, in order to make these kinds of associations. And right now, AI in the Thrive project is mostly used at this fundamental research level in order to understand mechanisms. We are not ready for prime time yet in order to use these types of AI techniques routinely.
Thank you. Liver cancer is also definitely a very important topic. We see also European Commission with European Beating Cancer Plan really focusing on the cancer. Yeah, I would just like to thank you for diving into this topic that is very important also for ELPA and our community. Moving forward to Dr. Kather from Genial Project. So my question to you is, how is AI being integrated into the project, and what are its primary applications?
Thank you very much, Veronica. Thank you very much for having me here. So in the Genial project, what we are aiming is to understand liver cancer, specifically alcohol-related liver cancer, which is in Europe the one of the main causes of liver cancer, but it's an underappreciated, sometimes stigmatized disease that deserves much more research, and therefore we are specifically focusing on this. What we have learned in the last couple of years about alcohol-related cancer is that it arises due to a combination of factors. It arises due to environmental factors, of course, the alcohol itself, but also other nutritional microbiota, etc., but also genetic factors that patients carry within them. And so it is this combination that we want to understand. Now, to understand this, we are looking at large patient cohorts, so groups of patients that have participated in clinical trials, for example, screening trials or treatment trials. And during these trials, a lot of data is collected radiology, pathology, genetic data. This is much more data than any human can process, right? So it's absolutely essential to use artificial intelligence methods to cope with these data. And this is now, and we have already learned during the project time that we can have several interesting readouts from these digital data with artificial intelligence. One is that we can, of course, automate whatever humans are doing, right? For example, if you are looking at a radiology image and you want to look at the tumor volume, a human can measure it, but also AI can measure it. And it's just saving time. But also sometimes AI can find patterns that a human cannot see. For example, very small changes in the way the liver looks like in imaging that can predict the risk of cancer or risks of adverse outcomes. And so this is where we are using artificial intelligence as a tool, and we are trying to raise the awareness that this tool exists, that this tool is mature, and that for basically any clinical trial and any clinical situation where we collect data of our patients, we need to store these digital data so that later on we can come with AI methods and look at the data again and analyze it and try to find new patterns there. Thank you very much.
Thank you, Dr. Kather. Thank you to all three speakers, because you give a nice base for our first discussion regarding the integration of AI in healthcare. So I am opening this discussion with our first question for all three of you. So how do you envision this collaboration between then policymakers, healthcare providers, and AI researchers in ensuring that AI-driven innovations can be safely and rapidly adopted in clinical practice? What are your thoughts on that? Who would like to start? Maybe Dr. Kather?
Maybe I can start with one observation, and that is, if we're speaking about AI, there's two types of AI, okay? One is you have a certain data set and you train an AI model specifically on this data set to solve one specific question. We call this single task AI models. And everything that we mentioned so far is such a single task AI model, right? You want to have a model that predicts outcomes. You want to have a model that facilitates a diagnosis. For these types of AI models, we have a very clear guidance, and that is garbage in, garbage out, right? If we have bad input data, we will have bad predictions, and bad input data can mean a lot of things. Bad input data could mean that we have input data only for men, and we want to apply the final model to men and women, and it just doesn't work. Or we have it trained in different populations and we want to apply it to another population, it doesn't work. So bad input data basically for the context where we want to deploy these models. And I think I'm very, very curious what Georg and Manfred have to say here. I think we've learned over the years to be very careful in the type of data that we put in and to validate our models appropriately and to validate them for their intended purpose. However, when we talk nowadays, we talk about AI, there's another type of AI system that many patients think about when they hear AI, right? And this is generalist models, such as large language models, ChatGPT, right? These models were not trained for one specific purpose. They were trained on language, and you can talk to them about anything. You can ask them about anything, including liver disease, including medical questions. Of course, these models, so there's single task models and generalist models. And I think when we scientifically think about AI, we tend to think about these single task models, mainly predictive models, segmentation models, classification models, etc. But when we now, in what we've learned in Genial is that talking to our patients, they're all using ChatGPT or another type of AI system to become informed about risks of liver cancer, liver disease, to help them talk to their doctors, etc. These are generalist AI systems, and in fact, I think what we have to do is to develop different types of for each of these two applications we have to develop ways to cope with it and to ethically and equitably implement it in clinical care.
Yeah, maybe I can continue, and I totally agree, of course, with Jakob. I think one observation that we made is that it really pays off to very early in projects talk and integrate across disciplines. So I think it does not work greatly when you do your project and then at the end you have one meeting with policymakers or lawyers to discuss what you have done. But we are now trying in the projects to have parts of the work packages, parts of the project plan, legal experts involved, not to write contracts for the project, but really to try to understand how could we regulate, how could we create safety procedures, how could we kind of create a framework in which we can use AI in the clinical environment so that it's safe, and also that clinicians understand their duties and their responsibilities versus the AI, but also are comfortable because they know exactly what they have to do and where the risks are and what can be done in order to manage it. And the same with policymakers. I think there was a big discussion about exactly, Jacob, what you just mentioned, this difference between this single task AI and kind of the more Gen AI, as kind of the name is. And one thing that I learned from one of our colleagues, so Nicolas Forgo, from one of these projects, was that for policymakers, this single task AI, it's very comfortable because it's like an elevator, right? Like it goes up and down, and if you go in, you will end up in a different floor. But the Gen AI, the let's say the special thing about the Gen AI is not so much what it can generate, but what it can inject, or what you can inject, right? It doesn't do what we told it to do, but what it does kind of depends on the input to the model. So it's like an elevator that can go anywhere just because you're in there and saying, I would like to go there. And that's what makes it so, I think, difficult to understand and also kind of hard to grasp where are the risks, where do we have to kind of build in safety nets, and how can we do that, and how can we also inform patients who, of course, use these methods to understand where to trust them and where not to trust them, and how to kind of cope with that information, because of course there is a lot of useful information. And I think understanding the models is not something that should be kind of limited to the people who are developing the models, but really much more to the patients and to the clinicians, so that we kind of together develop a good way on using these models in the clinical practice.
Maybe I can also chime in here. I mean, the type of models that we are using in the Thrive project are these single task models, these elevator models that have a designated path that they take. And even for these types of models, in order to have them usable, it is important to integrate the use of these types of models already early on with clinicians, and allow the clinicians to look under the hood. I mean, to validate predictions that these types of models make. And this in practice is not easy. Besides our activity in the Thrive project, this is something that we see when we work together with molecular tumor boards, where specific patient decisions have to be made using statistical or machine learning approaches. And regarding these generalist approaches, in the end, as far as I can see, important decisions on patient treatment will always be made by doctors. And so therefore, it will be important, to also train doctors to deal with patients that come up with suggestions that they got from a generalist model.
And so how can then policymakers help address potential disparities in AI-driven healthcare outcomes to ensure that marginalized groups benefit equally from advancements in AI technologies?
Well, currently we have it's a very difficult regulatory landscape, right? I think we have to first make sure that basically anyone benefits from AI technology, because what is clear is that there's a lot of research about AI in healthcare, and but the implementation in clinical routine is very slow. And of course, as always, marginalized groups are even more disadvantaged. But I think it's also in our country, in Germany, but also in the European Union as in general, we are seeing basically universally a very, very slow uptake of AI in clinical routine. And there are approved AI methods, for example, in cancer screening that are being used in breast cancer screening, colorectal cancer screening that are used routinely throughout the EU. Some countries are much more advanced than others. Nordics, Netherlands are much more advanced in implementing such tools. But in general, I think we're lagging behind, and very, very few people overall benefit from AI in healthcare. And there's many reasons for this. I think what we are seeing, one main reason is implementation. The healthcare systems are just not digitalized enough. Some countries have universal electronic patient records, for example. Others don't. Netherlands is very advanced there. Germany is very much behind here. So the infrastructure is not in place. And we see pronounced disparities here, right? So, for example, in Germany, to sign up for the electronic patient record is super complicated and involves many steps that some people can, like young people, can do this much more easily than old people. So therefore, they are disadvantaged, right? So I think we have to reduce the structural burdens in implementing this technology. And the other thing is, of course, the regulatory landscape. Right, we cannot, I think, stay silent about the fact that in Europe we have the probably most difficult regulatory situation globally. We have to look at GDPR, EU AI Act. We have to look at MDR, IVDR, and sometimes they contradict each other, and sometimes it's not clear which AI model is regulated by which framework. So I think what is clear here is that if we want to have these AI models for our patients, regulation has to be safe, but it also has to be workable and has to be minimal, ideally, right? Because if in the current situation, what we are seeing is that there is a shadow use of AI. Many patients use ChatGPT or other large language models, which are not approved or validated at all, right? They are completely outside of any regulation, and people just use them for healthcare purposes, although they're not approved medical devices for this purpose. And I think that's the worst possible outcome, to have so much regulation that we have a shadow use of AI outside of the regulated area. And I think that this is clearly what we have seen in adjacent areas, that this clearly contributes also to inequality, right? So that certain for example, patient populations who are not as digitally native are much more locked out than from these technologies. So yeah, there's a lot we have to do, and we have to do it together in the EU, and that's one of the messages we're trying to address in our messaging through our EU consortium.
Any other comments to this topic, or should we move forward? Yes, we are moving forward. Okay. So I hear a lot of single task AI, Gen AI, new terminology for general public patient community. So we are already learning a lot. You mentioned also shadow use of AI. So I think this is a nice transition to our second topic, which is the ethical consideration, safety and so on. So Dr. Claassen, the first question is for you. What frameworks or guidelines are in place within Thrive, the project Thrive, to ensure transparency in AI-driven clinical decisions?
Yes, yeah, thanks again for the question. As I mentioned before, in Thrive, the type of research that we are doing is more fundamental or translational. And the type of models that we develop are this type of single task models that we are using in a research setting. And in order to be able to do this, obviously all the data that we use for this data, we have to have all the ethical approvals and patient consents available. And in that regard, our project is somewhat canonical and straightforward to implement. And later on, the type of results that we publish would first of all be the patterns that these AI models find in the molecular data that we study. And normally, the research that we do doesn't stop with the patterns. So typically, then there are additional research steps that validate these molecular patterns and verify that these molecular patterns are actually real, are really important, or are really mechanisms that are actionable. And only then you follow up on these types of results. And then obviously regarding the transparency, all the results that we come up with in the Thrive project, we publish in peer-reviewed journals, as well as the algorithms that we have developed and the models. And in that regard, all of the results that we produce are reproducible and transparent.
Thank you. Sorry. So, Dr. Claassen, you mentioned ethical approval, patient consent. Then my next question is to Dr. Langs. What ethical challenges are involved in using AI in healthcare, particularly regarding the patient data, privacy, and decision making?
Thanks. I think that's a super important question because it also plays into what the models do and what Jakob just discussed a little bit earlier. So I think on the one hand side, of course, there is the issue of data security and safety and making sure that nothing is revealed that patients don't want to be revealed and there is privacy around the data. But I think, and we, for example, are taking care of that. We're putting a lot of effort in the organization of how the data exchange happens during the project and who can access which data and who contributes to which data, and to make sure that ethical approvals, and also by now, not only ethical approvals, but usually also some kind of data clearing committee approvals are necessary in order to do that, and to really check a couple of times whether this data can be shared in the way we do in order to perform the research, because it's really important to share the data, right? So I think just not sharing the data to make it safe is not an option. And the reason for that is that we have no way of learning or creating machine learning models that have a chance of covering the immense diversity of patient populations if we don't work with multi-center data. So I think multi-center data is really one of the keys to having good and robust machine learning methods. And I think one issue there, or one point that I believe is relevant, is not only data security, but also, and I think the philosophy community calls it the right to inclusion. So the right for inclusion of my kind of data into these models, because very often, to be honest, of course, it's the easiest way to just use the data of the patients that are in our medical centers, right? Big university centers, but that's not a random sampling of the patient population. That's a very specific section of the patient population. And I think it's worth, and we have to do the effort to broaden that. And I think that's one of the reasons why I'm very happy about EU initiatives that work on pooling data and making data across many centers and countries available for research, so that first of all, these patients are covered, but also I think that the competition, that our, so to say, energy does not go so much into getting the data and who gets the best data, gets the best results, but rather who has the best idea in what to do with the data. And so I think that's one part of this challenge, making sure that the data that you are validating on and training on is really representative of a broad patient population. And the other, a bit more subtle effect that we see is that sometimes we see effects in the data that are really there, but that don't have anything to do with the treatment or the disease, right? So if you try to use, just as an example, how long does it take until the patient comes back to the hospital? If the patient doesn't come back for the hospital for a long time, that can mean the patient is fine and healthy and the treatment was really effective. It can also mean that the patient lives a long way away from the hospital, or it's really tricky for them to kind of leave their workplace to visit the hospital, right? And that might not be black and white, but it might be kind of subtle biases that kind of creep into your models, and that you have to make sure to recognize and to kind of, in the best case, also to kind of dampen and get rid of in your model. So there is always the danger that you kind of perpetuate some biases, some confounders that are in the data with your models. And I think maybe to close one on the method side, one thing that I think is an interesting direction is a lot of work is now undertaken to perform something we call disentanglement. So to see are there changes in, let's say, imaging data of patients in the patient trajectories? Are they or caused by actual disease and treatment, or are they caused by other factors such as different scanners, different centers where these patients are coming from, other factors that we actually do not want to enter our models and that we do not want to be part of the decision-making process. So I think it's on the one hand side a matter of paying attention to the diversity of your data and the representativeness of the data, but it's also an issue of actual method development to kind of cope with these biases and make sure that the methods are, so to say, fair and representative and help a broad patient population.
Thank you, Dr. Lang. As you mentioned also a very important point that I would like to stress out, you among each other and consortium, you have to share the data. And I think today's webinar is also a confirmation that Europe is able to do that and is eager to do that. And this is the only way to move forward, right? We have to talk to each other. We have to work together. And at the end, we have to make sure that patients are really safe. They feel safe sharing their data for the research. So my next question is to Dr. Kather regarding the Genial project. So how does the Genial project address potential inequalities in access to AI-driven cancer treatments across different European regions and also patient groups?
Thank you very much. So in the Genial project, we look at patient cohorts that we train, and we use artificial intelligence methods to train predictive models, diagnostic models on data from these cohorts. And once you have trained such a model, you have to validate it, you have to test it, ideally in other cohorts, right? To make sure that it's really that is really doing the job, not just in your training cohort, but elsewhere. To have and if a model performs well, not just in your training cohort, but also elsewhere, we call it generalizable, right? We say the model generalizes very well. So our aim is that the models that we train generalize very well across different geographies, but also across different patient populations. And these can be men, women, young, old, patients with different genetic risk factors. So what we do is we look a lot in these subgroups. We investigate we train these models, and then we investigate very closely different subgroups of patients. And what we usually find in AI research always is that the models perform different in different subgroups, right? But we want to have models that perform equally well in all subgroups. Now, what can we do? We can train these models on more diverse data. So that's basically the most robust fix. We have to collect varied data, train the model on these to ensure it generalizes well. And there's also some other technical tricks that we can do to, for example, data augmentation that we're working with. So to take data and change it artificially slightly to make the models more robust, more generalizable. We're also working with this on the technical side. In the end, our aim is to have AI models that work equally well for every patient group. Now, what we are encountering in this project and in any other project is that you're mostly limited by data availability, especially as we go into subgroups. We want to look at men and women, young and old people. We need to have sufficient patient numbers to train the AI on and to test the AI on. And this is where things usually get difficult, right? Because then you want to go into more granular subgroups, and then you just don't have these numbers anymore. And so we are well, of course, in our project, we're well equipped. We have large cohorts that allow us to analyze all the core questions. But then sometimes we want to ask a question, what about just elderly men or young women, are they basically predicted by the model equally robustly? And then we notice, well, now the numbers are not enough. So I think what we want to share as a call to action again is to make data available across Europe, across projects, and to make it reusable and just share it. And in fact, that's what our patients want. When almost always when we talk to our patients, they basically are massively pro and in favor of making data. In fact, in many cases, they just already expect that it's already happening, and then they're shocked when they learn that there's so many barriers to using digital data for research. So we're trying to raise awareness about this.
And particularly regarding the patient privacy and data protection, this is a question for all three of you. What regulatory frameworks or guidelines would you recommend to ensure that AI in healthcare adheres to the highest ethical standards? What would be your let's say 2 or 3 tips?
Well, there's the GDPR, of course, right? The GDPR in Europe is for us the framework that we adhere to always, and that gives us and our patients confidence that personal data is only processed with appropriate consent, right? And of course, in the clinical trials, we have this type of consent. Oftentimes, you want to do research on retrospective data, where it's basically this type of patient-specific approval does not exist. In this case, national legislation in our country allows us to do research on anonymized patient data. So if we really strip all patient-related information from these data, then the data is considered anonymized, and we are allowed to do research with this, which I think is absolutely reasonable, and it's what our patients want. And it would be great to have this in a very clear and very strong way in European legislation, right? So that. I think the rules are there, and we're and we're adhering to them. But we're often the patients, they when we talk to them, they even expect to have more research friendly rules than actually are there. I would be very interested how it looks like for you, Georg.
Yeah, thanks. So I think very similar. So I think in Austria and Germany is very comparable. And I also would like to kind of emphasize what you just said, that the ability to work on retrospective data is really critical, because while you can use the trial data for very specific questions, of course, it's a very narrow patient population. So we need to be able to see what's there, what patient trajectories, what response patterns are there in the kind of real world diverse patient population. And I think currently really only the retrospective data is the possibility to do that.
And maybe also adding to this, I would also agree that being able to do these retrospective studies is very important, because there is a treasure trove of informative data in the basements of the clinics. Just mentioning, for instance, immunohistochemistry data that is available, plentiful and highly informative in order to learn a lot about disease development and treatment responses and so on. Yeah, that's important.
Thank you very much. You already are giving us a lot of information, a lot of suggestions. So we are moving towards our third part, and we will be focusing on AI in personalized medicine. So, Dr. Langs, the first question is for you. How does Artemis ensure that AI tools used in personalized medicine are adaptable to the diverse needs of individual patients?
Right. Thanks. So I'd like to mention 3 points. So the first one is that we see that we can use machine learning and AI methods that are analyzing the data to essentially, as Jakob said, automate what we are doing right now. But what we realize is that we can also use them to look for other patterns that we didn't know existed or that we didn't know had any predictive value before. And so we use some of the work in order to basically mine the data. In our case, it's magnetic resonance imaging data of the liver that shows kind of the changes of the tissue, that also shows how the tissue changes gradually from normal tissue to more and more severely diseased tissue, and also shows how this change can be, so to say, modulated by treatment. And we are looking at the data and using machine learning in order to discover what are patterns, what are tissue types that we can differentiate in the data that might be able to tell us a bit more about this progression of the disease. And that relates to the question because we realize that this taken together with other information we have about the patients is really informative in terms of telling us something about this disease progression. So sometimes what we see in the imaging data means very different things when we are looking also at the age of the patient, also at comorbidities of the patient. So I think these are ways of taking not only the imaging data or the molecular data into account, but also the circumstances like the comorbidity profiles of patients. That's one way of how we try to become better at predicting future progression for individual patients. And the other point is, and we briefly mentioned it before, that we see very simply signatures in the scans that come from the disease and the tissue patterns and all of the things that we are actually interested in. But a big part, especially in magnetic resonance imaging, a big part of the variability that we see in the data is just coming from the machines and coming from the teams that kind of tune the machines and configure the sequences that are used in order to acquire the imaging data, or from the overall environment. So some work is being put into disentangling these signatures. How can we separate what is the variability that is just associated with the scanner type or the scanner manufacturer from the variability that is actually associated with the biology of the disease? And that also helps us to become more accurate and more specific in finding these patterns that are actually predictive for the disease. And maybe the last point is, again, one where I think we are really just at the beginning, which is all about the implementation of these methods in clinical routine. And Jakob and Manfred already mentioned that as well. I think right now we are at a level where some of these methods in some of the organs start to be at the level where they're really ready for being used in clinical environments. But we are realizing that once we have them in the clinical use, they're medical products, that's all fine. We need to learn how we can use the results these algorithms give us in order to then influence decisions that are actually relevant for the patient. So I think at the beginning we thought that we imagined that to be a bit more easier than it is really, to find a good way to actually exploit the results that we get from the machine learning algorithms that are working on the data.
But we at ALPA are confident that the whole project consortium, you are experts in your field, so we are really trusting you that you will be able to play with this data. So Dr. Claassen, the next question is for you. I would like to know, in what ways is AI helping to tailor liver cancer treatments to individual patients within the THRIVE projects? Tell us a little bit more.
Yes. We are using machine learning tools in many different sub-projects in Thrive. And one thing that everybody sees is that machine learning tools are very powerful prediction tools. And oftentimes these types of methods and models are black boxes that just predict very well, but we don't always well understand on what grounds these predictions are made. But another possibility that you can use machine learning for is actually to look at complex systems from a different perspective. And that's something similar that Georg mentioned before. You can find novel patterns, novel perspectives to understand how complex systems like a liver in liver cancer works or does not work well. And one aspect that we are studying in Thrive is the involvement of microbiota in liver cancer. And there is a plethora of different microbiota that is present in the gut and also in the liver, surprisingly. And these collections of microbiota are like a dark continent. And it's so far not really clear how to look at this collection of microbiota in order to understand their relationship to liver cancer. And here we are using machine learning methods in order to define relevant groups of microbiota that have certain metabolic functions that are then mappable associated with liver cancer. And in order to find these patterns, machine learning is very helpful. And another way how we use machine learning to that end is to use widely available data types like immunohistochemistry data that by itself does not contain obvious information about molecular mechanisms. And what we are trying to do in Thrive is to map these type of widely available imaging data modalities to molecular patterns in order to then use these widely available data to make predictions on the basis of the respective molecular representations in order to more easily come up with mechanistic hypotheses why a machine learning model makes a certain prediction.
And Dr. Kather, what impact do you foresee AI having on improving patient outcomes through the personalized liver cancer treatments?
I think the impact of AI on personalized liver cancer treatment could be huge, right? It could be this technology is here. This technology is mature. This technology is very, very powerful, and we should use it as much as possible in situations where it's well validated. Now, there's some situations where this technology is very well validated, and that is, for example, in breast cancer screening, for screening for breast cancer in mammography, X-ray images. AI is as good as a radiologist. There's large studies showing this, and now also for screening colon cancer in endoscopy videos, AI is as good as a human endoscopist. So there are these situations where AI is clearly on human level or superhuman level, and I think it's unethical in such situations not to use it, not to offer it to patients, right? For liver cancer and liver disease in general, the evidence is there's much less evidence, right? So because these diseases are not so are very diverse, they're maybe not so common, very complicated disease. Occurrence in different populations, etc. So we're trying to understand this, but I think in the end, there's no reason why this should not help our patients tremendously, and I think we have an obligation to move this to clinical application as fast as we can, so that our patients benefit from this. Now, basically, what I just said is mainly about the specialized AI systems, right? For example, for screening or for prediction of outcomes, for prediction of treatment response. I think there's tremendous benefit also in the generalist or generative Gen AI methods like the chatbots that we have nowadays, even just informing patients about lifestyle, informing patients about risk, explaining, and people are using this, like millions of people in the European Union are using these chatbots, for example, for dietary recommendations, and are using this every day. And I think it could be tremendous. What we are seeing in studies is that this could be tremendously useful, especially in situations where you don't have immediate access to personalized counseling for lifestyle or other topics. But what we need is validation. So I think we need to validate to see where are these. Is this technology safe? Is it reliable? And when can we trust it? Should we be careful? And this is a big area where there's tremendous benefit to be unlocked, but also tremendous work to be done in order to make sure we unlock this benefit in a safe and equitable way.
Thank you, Dr. Kather. We are slowly moving towards the final part of our discussion, and I have two important questions from the patient community. So this is a question for all three of you. So what steps are being taken to ensure that AI technologies do not replace the human touch in healthcare, especially when it comes to doctor-patient relationship? How do you see this dialogue that we as patient community really want to keep there? You know, human touch is always important to be part of the patient journey.
Maybe I can
No,
start here. I think in that regard, what we are doing in Thrive is quite fitting, because we try to break down the phenomena that we see to these molecular mechanisms that, at least to an educated doctor, make a lot of sense. And if a model that we have developed were to be used in the context of a patient-doctor interaction, then the doctor would be able to understand what the model finds, and would be able to communicate this to the patient. So in that regard, more generally speaking, if we are dealing with AI models that are interpretable, then the communication between the doctor and the patient can work very well.
yes. Yeah, I wanted to add, so I agree totally that this explainability is something that can help, and that is necessary in order to kind of also allow the experts to correct some of the results, but also to understand them well enough so that to actually do something with them in order to kind of, well, judge their reliability, but then also to explain them. One thing that stood out to me, at least in the conversations that we had with patients, was that when we talked about when it is acceptable to use an AI, the feedback that we got was always that definitely if it's working well and if it's more accurate and a better decision than without the AI tool, then the AI tool should be used and should drive the decision. But the important point was that the final decision should always be done by the expert. And I think that the reason for that was maybe not even that the expert makes the better decision than the algorithm, or makes the better assessment than the algorithm, but more that if I'm a patient, the expert in the end is someone like me, and I would like someone like me to make the final decision about what happens with my treatment with me.
I fully
Dr.
agree,
Kather,
and I personally, I mean, when I go on a plane and I fly, I want to have a human pilot. It's probably irrational, but it's just how it is, right? When I go to a doctor, I want a human doctor, and I think this is probably not irrational in that case, but it's a valid choice, and it's a choice that most of our patients would also make. However, this means that ultimately we need a human. We want a human in control. We want a human in front of us who we can talk to and trust. Around that, there's tremendous potential for AI use. I think it's actually very good that patients are talking to ChatGPT before they come to the doctor, because they're more informed. Sometimes ChatGPT hallucinates and gets things wrong, and then we can discuss it in the conversation, right? Previously, patients went to Google and just Googled before going to the human doctor, and generally what we have seen across studies consistently is that large language models, Gen AI these days, gives us better recommendations than manual web search. So that's just one situation where I think it's absolutely valid and desirable to have AI, although ultimately a human is in control. Now, there are several situations already where there's evidence emerging that even having AI focused care can in some situations also be effective and safe. For example, there's a prospective randomized trial on AI based psychotherapy for depression, which met its primary endpoints, showing that just chatbot based psychotherapy can help for depression. Now, this was a smaller trial, right? And I'm not saying that we should use this universally, but I think this is pointing to the fact that that there are situations where AI can be helpful, can complement human care, and we have to validate it and to make sure it's safe and effective. Maybe as a last word, I want to say that in the context of these European projects, what we should emphasize is the topic of sovereignty in Europe, right? It's important, I think, that we have European models and expertise in Europe, and we're not just importing all the expertise. But right now, all the large language models, for example, every single one is imported except one French company that's making these models, the company Mistral. But all the other models are American or Chinese, and I think it's problematic that we're basically importing the AI models and the expertise. And I think it should be, especially in the context of healthcare. It's very important to have this capability in Europe.
Thank you very much for all of this input. You actually, half answer my second question, but maybe just as a final message or final statements from all of you. Maybe how can patient community, or also general public, better understand this AI technologies, because they are probably here to stay. So maybe you as an expert dealing with them on a daily basis, how, if somebody asks you from your family or just colleagues, how better understand this AI technology, what would you say to them?
I'm an avid listener to podcasts, and I think there is so much resources, or there are so many resources available at so many different expertise levels that explain complex phenomena like AI in beautiful ways. And I think that would be an easy way to address this. And maybe it would be helpful if via ELPA we could point to different levels of detailed example resources to that end to facilitate this.
Yes, I think totally agree. I think maybe just to add one point, I think I would ask your doctor if they used it and how they use it. And I think that's also great that becomes part of the conversation between the patient and the doctor.
I fully agree. Talk to the doctor, talk to us. I think that talk to a human, right? Talk to a human about AI, and also just use it and play around with it. But I think I encourage my patients to play around with this technology, to try to build an intuition about it, and then to discuss it with the doctor.
So thank you very much, Dr. Lang, Dr. Claassen, and Dr. Kather, for this very, at least for me, informative session. We will definitely share it with our ELPA network and wider. And I think this was not our last dialogue and conversation on this topic. So I'm really looking forward to more of this type of conversation. Thank you for being with us.
Thank you for having us.
Thank you.